So, with everyone's permission, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet is India's most trusted and widely used digital platform, offering a multitude of enriching services exclusively for the doctors. Clarnet is selected to be chosen as a digital partner for this event organized by Indian College of Anesthesiologists. So today's focus would be TCI-TIVA, Pharmacokinetics and Practice Guidelines. So let's begin today's session, for which I would like to invite Dr. Jayashree Sood ma'am to take over. Over to you, ma'am.
Thank you, Swastika, for the kind introduction. Good evening, everybody. It's a great pleasure to be hosting today's webinar, the 267th webinar. And as I always say, we are very proud of having conducted these weekly webinars, Wednesday webinars, continuously since COVID time. And we've completed 5 years, and it has been tremendously appreciated by the students. And this also goes on the YouTube, where the students, delegates can view it later on whenever they are free. The college has many honors, and we are very proud to tell everybody that we have a very nice program in which we concentrate, as you know, only upon the academics. We have several fellowships running in different hospitals, like Narayan Vidyalaya. In Hyderabad, we have the onco anesthesia. In Delhi, we have the thoracic anesthesia and the regional anesthesia, just to name a few. Palliative in Delhi is also running very well at the Safdarjung Hospital. We have a journal, the JICA, as well as the yearbook of anesthesiology, which is very, very, very popular. So today we have a very eminent group of speakers and the moderator today, and I'm very happy and proud to introduce them. The topic, of course, is the TCI and TIVA, which is the hot topic these days. And to moderate this show, we have Dr. Subramaniam, a very, very special moderator, a very senior person who is the senior consultant anesthesiologist and regional director of anesthesia services at the KIMS, that is the Krishna Institute of Medical Sciences at Bangalore. I know Dr. Subramaniam very well, and he has many credits to himself. And the most important that these days is the total intravenous anesthesia and patient safety in both in the TIVA and POCUS. He has a great interest, and he's also interested in regional anesthesia and solid organ transplantation, and of course the education and simulation-based training. He has several publications and awards, and he is one of the first certified digital health professional in India, which is so essential. He has 2 chapters in the yearbook of anesthesiology, as well as 5 chapters in the textbook of anesthesiology. He's the founder president of the AOTA, that is Association of TCI and TIVA. He's a member of AORA and the other committees. He has been a faculty in several workshops. So this was just a very concise introduction of Dr. Subramaniam, but I know he has many more credits. So Dr. Subramaniam, please start the moderation and kindly introduce the speakers so that we can go ahead. Thank you very much.
Thank you, ma'am. It's more about people who introduce, and you have been such a wonderful mentor for all of us. Thank you for bringing us on this platform. Today, I think our journey, it's going to be precise, it's going to be personalized and modern. So all this fit into this topic of target controlled infusion and TIVA. So we have got exciting, young, precision, smart people here who can take us to the next level of practice. This is the modern practice, or make it more precise. So first we have Dr. Shivakumar coming in. So he is the head of anesthesia at Subbaiah Institute of Medical Sciences. So he has a number of publications. He's such a gentleman that one of the pioneers in this field. No, not only has 31 publications to his name, he also has an innovation in his name. Use of virtual reality to train CPR in community. That was his innovation.
I think some network issue.
Dr.
You are not audible, sir. Yes.
Dr. Subramaniam?
Should I start or?
No, one sec. So, of course, he's having some network issues. The other speakers, of course, Dr. Shivakumar is there. Then we have Dr. Tanvir, Dr. Rajarajan, and Dr.
He came
Vivek.
back.
He's come back? Okay.
He's come back.
So, Dr. Subramaniam, please.
We'll first, the key thing is about understanding what are the basic principles. We have Shivakumar highlighting us the basic principles, why TCI-TIVA, what is behind that. After that, it gets more interesting. Dr. Tanvir will come in. I will introduce more because she's a person with enormous personality. So for somebody with an IP right with her, Rajarajan Ganesan, a young guy from PGI who is making waves and has used closed loop anesthesia. What else? No, we want to hear. I will tell more about him as we go ahead. And Vivek will come to us at the end to make sure that we are driving anesthesia towards the right direction. That is using depth of anesthesia monitoring in everyday practice. Shivakumar, I will hand over to you. You will start off the presentation and then we'll join.
Thank you, sir. Thank you for the introduction. I welcome all the delegates and senior faculties, and I really appreciate the ICA for giving this opportunity. So I'll be talking on basics of TCI-TIVA. Can everybody see my slides?
Yes, Shivakumar, we are seeing.
Yes. Topics allotted to me is basics of TIVA, that including bed principle, pharmacokinetics, and pharmacology. So no conflict of interest. So I'll be brief. My outline of talk is basics of TCI pumps, bed principle, which is the main pharmacokinetic principle in practice of TCI-TIVA or TIVA. And I'll be discussing about effect versus what is plasma site targeting. Various TCI PK models will be dealt by Tanvir madam. I will not be discussing on PK models, context sensitive of time, and how to practice a TCI-TIVA safely. This is my outline of my talk. So come to a definition of total intravenous anesthesia. We know that it's a technique where we use intravenous agents to induce as well as maintain a general anesthesia, avoiding usage of inhalational agents, including a nitrous oxide. This is a total intravenous anesthesia. So what is target control infusion? It's a computer control system that uses an infusion pump to maintain a set concentration of anesthetic agent either in a plasma or FX site. The pump will use a pharmacokinetic model to calculate the amount of drug to infuse to maintain this set target concentration. So we are using a concentration rather than mg per hour or ml per hour. So we are setting a target concentration. The pump will decide what is the infusion rate to maintain a set target concentration. So coming to a TIVA TCI pumps, these are automates the dosing of intravenous drugs during anesthesia by coding to a pharmacokinetic model into a computer program and linking into an electronic pump modified to accept a computerized commands. These are looks like a similar to a syringe pumps, but they are incorporated with computerized pharmacokinetic models. So delivery of the drugs will be based on the set concentration and patient specific pharmacokinetic profiles. Then so that this set concentration can be achieved by using these PK models. What are the different parts of TCI pumps? We have a user interface where you will put what is the concentration required, patient demographic profiles, and other things you can input like height, weight, lean body mass, or total body mass, whatever the each model will ask, you will put in a user interface. The microprocessor with the various pharmacokinetic softwares. Each drug may have a different software we have to select based on the patient's condition. Then infusion pump which delivers up to 1200 ml per hour, which is required because in case of rapid sequence induction, we need to induce a patient at the faster rate. That's why the high 1200 ml per hour is required. The further infusion will be dependent on what is the drug, what is the concentration we have set, and what is the redistribution. I will be discussing of that in a later part. And visual and auditory safety system and alarms will be there. Maybe occlusion alarms or a disconnection alarms or patient syringe empty alarms will be there, like any other syringe pump. And most importantly, KVO, that is keep vein open, must be deactivated. When the syringe is at the end of empty or nearing to the empty, normally when the KVO is activated, the flow rate will be decreased to a minimum to maintain the patency of the vein or cannula. That should be inactivated in case of TCI, a practice of TCI-TIVA, because when it comes to if the KVO is activated, the drug delivery will be minimum. Patient may be aware if KVO is activated. So it must be deactivated. Coming to a pharmacokinetics, we all know when you give a drug, a bolus drug, initially it raises in a V1 compartment, that is a plasma concentration raises, but over a period of time it falls. This fall in a drug concentration is not due to elimination, mainly due to a redistribution of drug into the various compartments. So it increases immediately, then falls in a rapid depending on the pharmacokinetic of drugs. Most of the drugs like propofol, if you give it, falls to a within 10 minutes the drug effect will goes away. That is because of redistribution. But what happens when we give a drug as an infusion? So this is based on the 3 compartment models. Normally in a practice of TIVA, we should know the 3 compartment model. So when you give a drug, when you start a TCI-TIVA, when you give a bolus or when you give a fixed dose infusion, initially what happens, drug will be injected into central compartment. That is a V1. This is a mathematical compartment as it comes to a TCI-TIVA, but you can consider as a plasma. It is comparable to the plasma. The drug will go to the V1 compartment. So then it will be redistributed into vessel-rich compartment or fast compartment like muscles and liver. So the drug concentration will fall because of redistribution into the vessel-rich compartment. Then slowly it will be redistributed to the vessel-poor compartment like adipose tissues. So these redistributions are governed by a certain rate constants. These constants, rate constants varies with model to model. So these are exponential process. Some models are fixed constant, some models are variable constant, that will be discussing in when we come to each individual models, that will be discussed by Tanvir madam. So then when this redistribution is happening, so meanwhile some of the drugs will also eliminated or metabolized, and very small amount of the drugs will go to the effect site. The effect site for anesthesiologist is a brain. It will also go into the effect site. This is governed by KE0. The KE0 also varies from a model to model. So the steady state between V1 and a brain, it depends on a concentration in a V1 and KE0. So that will determine how fast or how slow the drug will reach a brain. So achieving a constant plasma concentration, our goal is to maintain a constant plasma concentration throughout surgical procedure based on the surgical stimulus. So initial bolus is quite easy to calculate. It depends on what is the concentration is required in a central compartment and what is the volume of distribution. That is the amount of the drug we have to give as a bolus. But maintenance infusion is more complicated, has to match with the rate of decline of a plasma drug, which is due to the redistribution in the different compartment as I described before. The initially high rate of infusion is required because of rapid redistribution into the vessel-rich compartment. Over a period of time, the amount of drug infused through a TIVA or TCI-TIVA decreases remarkably because the V2, V3 will fill up over a time. Ultimately, in a case of propofol, if you infuse for 20 hours, V2 and V3 and V1 will reach a steady state. The amount of drug infused will equal to that of the amount of drug which is eliminated or metabolized. I think it's understood. So coming to a basic principle of TCI is target control infusion pumps calculate the bolus dose depending on what is the concentration we set. The speed of subsequent infusion will be depending on the what concentration we set and the redistribution and the model, what is the pharmacokinetic model. These calculations are repeated every 10 seconds, which is impossible when you giving a manual infusion. These infusion rates are adjusted every 10 seconds to maintain a constant plasma or effect site target concentration. The diffusion of drug from a plasma to a brain occurs exponentially with the first order kinetics, which depends on Ke0, which varies with the model to model. This is a simulation of a target control infusion with respect to a manual infusion. If you give a target control infusion, you see on the left side of the graph. So initially bolus will be, suppose we have set a target of plasma target of 4 micrograms. So initially the rapid initial infusion rate is given at the rate of 1200 ml per hour. Green color is effect site concentration, red is a plasma site concentration. In this model, they have set 4 microgram. You see the effect site concentration reaches very fast. After 15 minutes, infusion rate is 79 ml per hour and brain concentration equal to the plasma concentration, that is 4 microgram. Contrarily, when you see a manual infusion of 10 mg per kg per hour, so it will take 40 to 90 minutes to reach a plasma concentration of 4 micrograms depending on what kinetic model used to calculate the effect site concentration. So at 15 minutes, the effect site concentration or a brain concentration is only 0.9 microgram per ml. So contrarily in a TCI, it already reached within 15 minutes, the plasma concentration reaches steady state level with the V1. But after 30 minutes, in case of manual infusion, brain concentration is 1.1 microgram. See, it requires 40 to 90 minutes. If you use a fixed dose infusion to reach a plasma concentration, it will be very slow. Unless you give a bolus, the plasma effect site concentration will not be reached fast. So TCI-TIVA is very important because the effect site concentration will reach us faster and it will maintain the constant effect site and plasma site concentration. And it is likely that an inadequate clinical effect would be observed in an initial time if you give a manual infusion in a fixed dose manual infusion. And if you continue a fixed dose manual infusion over a period of time, it will be higher than what is the therapeutic concentration or a brain concentration required for anesthesia. That will be overdosing. That will cause a post-operative cognitive dysfunction and there will be isoelectric waveform in EEG. Even NAF5, which was a national audit project which was conducted in 2008 in a Royal College of Anesthesia, they have also mentioned that fixed dose infusion or manual infusion should not be practiced for TCI-TIVA. TCI-TIVA should be mandated if you are giving a general anesthesia using a intravenous agents. Coming to understand the basic things of plasma, what is the plasma and what is the effect site targeting. In a plasma site targeting, what we generally does, we set a target in a plasma. Suppose I set a target of 4 microgram in plasma. So there won't be a overshooting above the plasma concentration. In a plasma site targeting, the effect site concentration will reach very slowly because there won't be overshooting. So suppose in this upper graph, you can see there's a green color is a plasma concentration we have set. But effect site concentration reaches very slowly when you set a plasma targeting. Slowly it reaches. Contrarily, when you use a FX site targeting, there will be overshooting above the set concentration. Suppose if you set a 4 microgram concentration, the plasma concentration may be overshooting more than 12 microgram. So that it is over pressurizes V1 compartment to reach a FX site concentration very fastly. So these advantages are also there, disadvantages are. Advantages is in FX site concentration, the induction will be faster, but hemodynamic disturbance may be there. So you should be very cautious when you're selecting in a patient with frail patients or a patients with the hypotension or hemorrhagic patients. You should be very cautious in selecting a FX site targeting. Coming to a plasma targeting, it is a safe in certain patients, but disadvantage is the patient will take a longer time to become unconscious or to reach a surgical anesthesia. These are the main differences between plasma targeting and FX site targeting. Plasma targeting is you are setting what concentration is required in a plasma. In FX site targeting, what concentration you required in a brain. That is the difference between plasma targeting and FX site targeting. So what is the time to peak effect? Time to peak effect is when you give a drug, intravenous anesthetic agent, what is the time required to produce a peak effect in a brain? That is to produce the unconsciousness for anesthetist. So that is a peak effect. Graphically, if you say when the plasma concentration intersects the FX site concentration, that is the time where time to peak effect is reached. That is the time. This interaction, the interjection of plasma concentration and FX site concentration is the time where the maximum effect is produced by a intravenous anesthetic agents. So coming to a context sensitive off time, which is very important when you're practicing a target control infusion or a TIVA, because you need to understand which drugs have a lower context sensitive off time, which drugs have a higher context sensitive off time. So we know what is a off time. Normally off time is when you give a certain drug, it decreases by 50% after certain time. That is a normal off time. Coming to context sensitive off time, when you infuse a drug for a prolonged period, when you stop the infusion, what is the time required to decrease by a 50% is called as context sensitive off time. When you give a bolus of thiopentone and propofol, the off time is similar, almost effect will wear off similarly. But when you give an infusion of thiopentone, the patient takes longer time to recover. That's why thiopentone never used as an infusion agents in normal practice. So these are the drugs which have lower context sensitive off time and suitable for continuous infusion, either in the form of target control infusion or a total intravenous anesthesia with a continuous infusion. Especially remifentanil, etomidate, propofol, and ketamine, sufentanil are very good for a infusion. Certain drugs like dexmedetomidine and midazolam also suitable, but the recovery may be delayed in a dexmedetomidine and midazolam. And these drugs should not be upper color like diazepam, fentanyl, and thiopentone should not be used for a continuous infusion. Even fentanyl, if you are using, you should be given intermittent bolus. Of course, we don't give a diazepam or a thiopentone as an infusion. These TCI models, there are various TCI models are there. I will not be discussing in detail. There is a propofol, they have Marsh model, Snyder model, and nowadays Eleveld model is also there. I will not be discussing. There will be next speaker will be discussing on these things. So in the pediatrics, this is a general purpose. That is LVL model is the recent model which can be used most of the patients and different kind of a pharmacokinetics. So this will be discussed by next speaker. Pediatrics, we have a LVL model, we have a Kataria and a Petfuser models also. So this will be coming to a practice of TIVA. So before when you start practicing, you should, there is a terminology called as peruse before you infuse. What it means is, you see that coming to propofol in the syringe, first you draw the syringe in the propofol into the syringe, then whether propofol on the pump. Before you putting a demographic details, weight, height, and other parameters, you have to draw the syringe, draw the propofol, put it in the TCI pump, then only you program it. So that's the first thing. Never program before then you start putting the syringe, because if you program it for remifentanil, then you put a propofol, then maybe underdosing. If you program it for a propofol, if you put a remifentanil, then it will be a overdosing. So that's why always load the syringe, put the syringe into the TCI pump, then only you program the TCI pump. Second is empty ampoules should be kept. You should not be discarded, because you have to verify whether you has 1 mg or 2 mg of remifentanil, whether you has 1% or 2%, whether you has proper drug has been used. So you have to cross verify with the loaded drug with the ampoules. Coming to remifentanil should be loaded, then you should be put in the syringe similar to the propofol, then you should program it. Then user settings, are the patient characteristics are same, whether you have put a previous case parameters, then you are loading. You should not never do. Switch off the pump when you finish the case, then load it, then again you have to program after loading the syringe. Are they same patient you have put? You have to verify that. Then whether you have the set up giving set, where now appropriate giving set are used, whether these sets are primed, unclamped, are connected on both the ends, whether you have used the lower lock connectors, whether any disconnections, whether vein is visible, as there is any extravasation is there, whether drip is running, you have to verify, because our anesthesia is entirely dependent on patency of these cannulas and appropriate placement of these cannulas and connection of a giving set from the pump to a patient's cannula. Then coming to a last, electricity, whether it's connected to electricity or is sufficiently charged, you should check. This should be checked by 2% positive confirmation before starting a target control infusion. This is as per Association of Anesthetic. Coming to briefly about the guidelines for a safe practice of total intravenous anesthesia, this has been published by a Society of Intravenous Anesthesia in association with Association of Anesthetists, Royal College of Anesthetists, Intensive Care Society, and Faculty of Intensive Care Medicine. So, first one is all anesthetists should be trained and competent in delivery of TIVA. Schools of anesthesia and training bodies should provide a teaching, training, and practical experience of TIVA to all the anesthetics and also intensive care medicine trainees. Second, when general anesthesia is to be maintained by a propofol infusion, use target control infusion is recommended. The most of the awareness as per NAP 5 project is due to use of fixed dose infusion or not using a TCI-TIVA. Then in case of frail patients or patients with bleeding or unwell patients, starting a target concentration should be chosen depending on their pharmacokinetic conditions. You should start very slow with a lower concentration, then increase slowly, because in some patients the requirement will be very less. Maybe some patient may require, elderly 90-year-old may require only 2 microgram propofol concentration rather than a 4 to 5 microgram in pediatric patients. That's why you start with a low concentration, gradually increase, so that there are two advantages of doing this. One is the hemodynamic perturbations will not be there. Second is you are not causing burst suppression, especially in elderly, which will cause post-operative cognitive dysfunction. Then within anesthesia department, it is preferable to stock only one concentration of propofol, and you should make the uniform dilution of remifentanil. Suppose either you keep a 2% of propofol or 2 milligrams of remifentanil, concentration should be uniform in a particular department. Either you can select 2% of propofol or 1 mg or 2 mg depending on your institutional protocol. The infusion set through which the TIVA is delivered should have a lower lock connection to prevent a disconnections, an anti-siphon valve on a drug delivery system, and anti-reflux valve on the fluid administration line. This will prevent a flow of the drug from a TCI pump into the fluid. Otherwise, the drug may flow, take a low resistant zone and going to the fluid. To prevent that, you should have a anti-reflux valve on a fluid administration line. Otherwise, you have to clamp at least when you are initially, when you are starting or changing the concentration, you should clamp the fluid administration line. 6th recommendation is the infusion pump should be programmed only after syringe pump has been placed into the TCI pump. Already I discussed that. The intravenous cannula or central venous through which the drug is administered should be visible, practically should be visible throughout anesthesia. Or you should check, if it is not visible, you should check frequently so that there should not be disconnection or extravasation. The anesthetist should be familiar with the principle and interpretation of and limitation of process TEG. Why it is important is you should never depend on either entropy number or a BIS number, because each anesthetic drugs have a different waveforms for anesthesia. Suppose if you go with Propofol, there will be alpha delta. If you go with sevoflurane, the alpha, there will be a theta delta. There will be a dexmedetomidine. There are different waveforms will be there. So that will be discussed by next speaker. So I will not be discussing on that. So you should be familiar with EEG waveforms and EMG also. Here is EMG activity is there. Where BIS, if you are using, whether you have a quality of waveform is good. So you should all check, and you should know basic about process TEG. Use of process TEG monitor is recommended when neuromuscular blocking is used. And another thing is, whenever this altered pharmacokinetics, especially frail patients, these patients use the process TEG to adjust the dose of a concentration of drug, intravenous anesthetic drug. The 10th is when a TIVA is administered outside the operating room, same precautions and same standard of practice should be taken when you are administering the operating room. Same principle should be there when you are administering in NORA setting or in the OR room. So coming to a few advantages, I'll not going to the details of advantages of a TIVA. The few advantages, one is coming to a central nervous system. You all know that it reduces ICP, except few drugs. Most of the, like especially Propofol based anesthesia, it reduces a ICP. It reduces a CMR. Then it reduces CMRO2 and maintains the cerebral autoregulation. So there will be less edema, especially traumatic brain injuries. Coming to immune system, we know that there will be it is an antioxidant, free radical scavenger, anti-apoptosis, anti-inflammatory, especially Propofol based anesthesia. In a renal, there are a few studies which have produced they have extrapolated that in cases of TCI-TIVA, there will be less incidence of acute kidney injury, especially in a cardiac surgeries, especially in a cardiac valve surgery. Coming to a cardiovascular system, reduced inflammation after a cardiopulmonary bypass, no overall survival benefit when compared to the inhalational agents. Gastrointestinal is a well-known advantages of a TCI, Propofol-based TCI device, decreased PONV. Other advantages, you can start a post-operative feeding within 1 hour because gut motility is not affected by a Propofol-based TCI-TIVA. The post-operative pain, there are studies which say that post-operative pain and requirement of analgesia are reduced when you use a TCI-TIVA. In case of oncological surgeries, there are a benefit. The recurrence rates, especially with the breast cancer and hepatocellular cancers, have reduced because it will not suppresses the cytotoxic NK cells. And most important advantages, especially in older patients, this will decreases the post-operative cognitive dysfunction. This is the most common disadvantage, especially when whether you use a neuroaxial blocks or use a inhalational analgesics. Post-operative cognitive dysfunction is very common, especially in a patients with dementia. This will be decreased significantly if you use a total intravenous anesthesia, especially with the target control infusion. But make sure that you should not cause a burst suppression when you're using a TCI-TIVA. So to prevent a burst suppression, you should monitor the depth of anesthesia. To conclude my talk, the clinician should become familiar with the pharmacokinetic and bolus elimination transfer principle before starting TIVA in their usual patient population. All the pharmacokinetic models have inherent assumptions which generate elements of inaccuracy in prediction. However, inter-individual variability in a pharmacodynamic response represents more challenging aspect of using a TIVA but use of either DSC or use of depth of anesthesia monitor decreases this inter-individual variability because dose can be adjusted based on these process EEG parameters. Depth of anesthesia monitoring during TCI-TIVA is decreases accidental awareness. More importantly, what we are seeing is the complications are much more if you give a overdosing. That is, if you increase the depth of anesthesia, if you increase the depth of anesthesia, there is a burst suppression is there. The patient is develop post-operative cognitive function. There are two advantages of using a depth of anesthesia monitoring. One is prevents the accidental awareness. Second is it also prevents the post-operative cognitive dysfunction. The elevated model, which will be discussed by Madam Tanvir Madam. So, which is a universal model, which is the future of target control infusion TIVA, especially for propofol and also for a remifentanil. So it can be used for most of the patients. Thank you. Everybody join IOTA, the newly formed association of target control infusion and total intravenous anesthesia. Thank you all. Thank you.
Thank you, Shivakumar. Just be online for a minute. We will take the questions at the end. But just to expand on a few things what you have talked about, TCI is one form of total intravenous anesthesia, perhaps the best form of total intravenous anesthesia. If there's anything different, you please enlighten us. You also mentioned it makes it specific and personalized. What patient characteristics does these models use to personalize and characteristics, and to what patient characteristics does it use?
So coming to this is what we is precision anesthesia or personalized anesthesia. Can I go ahead, sir?
Yeah, please. We'll finish it off.
So what is generally what we do is when you're giving a inhalational anesthesia, we don't consider a patient's weight, height, lean body mass. We won't consider also. We depends on certain parameters, especially we see the MAC and we administer. Some places MAC may not be available. Here what we take a gender, height, weight, and various models have a not only total body weight. Some models take a total body, but newer models have a fat-free body weight. So you have a elevated model with a fat-free body mass. In a Schneider model, we use the lean body mass. So, and also we consider whether there is co-administration of any other drugs like opiates. So, if you are using this TCI model, suppose if you are using opiates, the amount of it will take a consideration of opiates and decreases the dose of a propofol or any other intravenous drugs. So in this way, we will decrease and maintain the optimum concentration based on the patient's pharmacokinetic and pharmacodynamic characteristics.
Thank you, Shivakumar. Thank you. So be online. We will get you back again for any questions. That brings us to a very interesting turn now. So you mentioned about TCI being a very fantastic form of giving IV anesthesia, and it is personalized based on these patient characteristics. And there are a number of pumps and number of models available. Now, to elucidate with what are the different drugs available for use and what model to you choose when using different drugs, that is what our Dr. Tanvir Sharma is going to elucidate to us. But what is interesting, Tanvir, welcome to the webinar. Now, you are one of the few anesthetists who have a patent in your name. Can you just tell us what is your patent on and then move on to the topic? It's wonderful that we have an anesthetist who has a patent as well.
Yeah, it's a patent. It's called IV Alert. It's an infusion alarm device. So it's I could have got a photo if it was there. So you have a fluid bottle, and it gets the apparatus is attached to the fluid bottle. The fluid bottle hangs, and you can set different target volumes which you want. Suppose you have a patient of renal failure. You don't want too much IV fluid to go. And what happens in the post-operative rooms is that one sister is looking after 20 beds, 30 beds. So, and you are inside in the OT monitoring the patient. So by the time when you come back, you find out that you were supposed to give just 100 ml, but it's 500 ml of fluid which is already rushed in. So that infusion alarm device sounds an alarm once when the target volume, it is, the target has been reached. It sounds the first alarm at, when just 10% of it is remaining, then it sounds an alarm when just 5% of the target is remaining, and then it sounds an alarm when the target volume is achieved.
Fantastic, Dr. Tanvir. Now, along with having this patent, Tanvir is an additional professor in PGI. She has 130 plus publications, enormous number, and also a FICCI award winner. We can't have a better person to take us through the journey of various pumps available, various models available, and which model to use when we want to use the drug. Tanvir, the stage is all yours. We want to hear more from you about all this. Thank you.
Yeah. Yeah, thank you so much. And I really thank you for the opportunity. Now, I'm being very fortunate enough that Dr. Shivakumar has already introduced, the terminologies which are going to be discussed further in my slides. And there are lots, anesthesia is always a very personalized branch. There are innumerable anesthesia the beauty of the TCI pumps is that, again, there are lots of models which are available. Each will be having their advantages, disadvantages, and as in which I will be telling you about basically the different PK/PD models and the limitations of the models. I will be, giving you a lot of food on the platter, which you can then choose according to, your practice, your availability of, drugs, availability of other gadgets which are there in your center. Right. So we've already discussed that the main purpose at the end is that whatever drug you give, you want that the anesthesia should be balanced, and the anesthesia should be not too much and not too little, right? Like Dr. Shivakumar said that sometimes, a patient might be aware. So what all we want to, main target we want to achieve when we give anesthesia is that we are giving the right amount of drug and we are putting it at the right effect site, which he's been talking about. And the TCI pump, which he has already defined, is basically a device which is helping us to maintain the steady plasma or effect site concentration of the various anesthetics drugs, which he had discussed, in his previous slides, like propofol, remifentanil, and some of the few other drugs, which can be administered using TCI pumps. And the difference between the various TCI pumps, which I will be discussing, are basically on the PK models. What are these PK models? They are the mathematical algorithms which have been devised to calculate the different compartments. So this slide you've already seen before, and you know that there are various compartments. The ultimate place where we want the anesthetic drug to act is the CNS, the central nervous system, which we call as the effect site. Whenever we give a drug, a bolus, especially a bolus followed by an infusion, it is going into the central compartment. And initially, it is the equilibrium between the central compartment and the effect site, which is the first equilibrium, and the constant KEO, which we have for it, which is going to decide how quickly the drug is, you're going to have the effect, how much you're going to have the effect, right? Then we have other compartments also, the V1, the V2 and the V3, which are being called the rapidly equilibrium compartment and slowly equilibrating compartment. Now, Dr. Shivakumar has already discussed about this, so I will not go into the details, but it is very important that for you to understand that the various TCI pumps with their own models have the parameters of patient's age, weight, height, and sex, which we enter at the start of anesthesia before we start anesthesia, which are going to calculate what are going to be the values of the V1 compartment, what are going to be the values of V2 compartment, V3 compartment, and the various rate constants, which I have mentioned in the slide. So it is very important, especially for the residents, to understand that these models, they are not true anatomy of the body. This is something which has been devised to make, the understanding very easy, so that you can link yourself and help calculate the predicted plasma concentrations, right? And you can avoid any excess or deficit, right? As I told you, models are derived from the specific population, and you might have some variability when you're going to use in the large population, which has lot of variability, which you experience every day in your anesthesia practice. So although, nothing is 100% efficient, nothing is 100% correct, accurate. So it is the vigilance of the anesthesiologist and the experience of the anesthesiologist in using the TCI pumps, which you gain over the years, that, you can make full utilization. You can recognize whether your dosing is effective, whether your plasma effect site concentration as desired is being achieved, and ultimately you want to, prevent any side effect of awareness or overdosing or toxicity of the anesthetic drugs. So we have already discussed this also, that how does the TCI pump work? Basically, there's a microprocessor and the PK/PD profiles of the different drugs as in the form of an algorithm are already feeded into it. You enter the target plasma or effect site concentration which you desire. The microprocessor will calculate the drug needed using the algorithm and the various covariates, which we mentioned before. And then it is going to give a direction to the infusion pump to deliver the drug as a bolus and then as a maintenance infusion fluid. The main difference between a TCI pump and the conventional pumps which you have is that, it can give very high rate and it can calculate based on the algorithms, and every, like Sir said in the previous slide, every 10 seconds it can change, which is impossible when we do it manually. So this is another TCI pump which, I have shown you. The initial one was BD Claris, which was shown by Dr. Shivakumar. Now, this is the most important slide for you to understand, is that, there are various models which are available. The models are different for different drugs also. Like in this, you can see the propofol drug can be administered using the Marsh model, the Schneider model, and the Eleveld model. For pediatrics, we have the Ketaria and the Pedfuser. For fentanyl, we have the Schaeffer model. For remifentanil, we have the Minto model. Then we have the other drugs also, which we don't generally use in India, alfentanil, sufentanil. So we are not very well versed practically also with these drugs and the models. Midaz is not recommended, so we are not using. Then we have dexmedetomidine, for which we are using the Hennevoort model. So the bracket shows the various years of how they have been evolving, right? And the cutoff age groups, if like we had told you in the previous, when you're using propofol, generally the Marsh was for children, for people more than 16 years. Schneider was also for adults. It was only when Eleveld came, we got this very wide range from, pediatric to geriatric age group. So that's why this is the one which is now most popularized, most preferred. Ketaria and Pedfuser were specifically for pediatrics, but still you can see the age group for Ketaria is 3 to 16 and the age group of Pedfuser is 1 to 16. Now, what is the important parameter, for you to understand when you're doing is that you must know what are the rate constants which are fixed parameters and what are those which are the variable parameters. Like if you see in the Marsh model, you will find out that the V1 is variable, V2 is variable, V3 is variable. All rate constant are fixed parameters. As compared to the Schneider model, where you see that the V1 is the fixed parameter, right? And the V2 and the some of the rate constants are the variable parameters, right? And it is also important for you to understand that, they have different covariates which have to be entered or which decide what is going to be the bolus drug which is going to be administered, how much infusion it has to be given. For the Marsh model, it is the weight, right? And when you're talking about the weight in Marsh model, it is very important that it is the total body weight which you're using for the Marsh model. Now, in the Schneider, similarly, you see you have to enter the age, the height, the weight, and it is basically the lean body weight which is being used. I am not going into the formulas of total body weight, lean body weight, that that you can always get back and find. But you must understand what are the different covariates. For the Eleveld also, you have to put the age, gender, height, weight, and as it has been emphasized before, it is using the fat-free mass, right? And it's also accounting for any co-medication which is being given. Now, it is very important because once when we give anesthesia, anesthesia is not, it's a component of, hypnosis, analgesia, and we're using always a multitude of drugs. We're not depending on a single drug. That is the other advantage of Eleveld. We will be talking further. Similar, if you see the other models, you will find that the covariate weight is covariate for the pediatrics, both Ketaria and Pedfuser. For remifentanil, when you're using the Minto model, it is age and lean body mass. So a knowledge about what is the covariate, which is the variable which is fixed, which is the variable which is variable. That will help you to find out how your induction is going to occur. Is it going to be fast? It is going to be slow, right? We have already discussed that in the Marsh model, which is the first model which was developed, and that time it was called deprefuser infusion device. In this, the covariate is the patient's weight, and that is what is defining V1, V2, V3, and it is based on plasma site targeting. Now, Dr. Shiv has very nicely explained in his previous uh, slide that, if something is plasma site targeting, how is the induction? If something is effect site targeting, how is the induction? So I'm not going to repeat it, right? We know that it has to be used for people more than 16 years of age. And it is to emphasize that the original model didn't include the KEO, right? So you could use only in the plasma mode. But now when you have the modified Marsh model, so we have introduced KEO, and the KEO value is 1.2 per minute. All these things you will understand much if you start reading it. It is very important that at this stage, especially for the residents, if they just know the different names of the models and what are the covariates which are there for each model, and what kind of body weight has to be entered, that will be enough for them at the end of the talk. Second, which we talked about, was the Schneider model. The Schneider model was developed, after the Marsh model. It was in 1998. Marsh was in 1991. And what is very important for you to understand is the number of patients on which it, which have been used for making the models are very small in number. So that is what we want to emphasize, that you might have some variability when you're using it in the large patient population. Right? So the covariate over here is the lean body mass. Now it was total body mass for the Marsh model. Here it is the lean body mass. Then age, gender, height, everything is there. Now, as in the Marsh, it was plasma side. Here it's predominantly effect side, right? The age cutoff is 25 to 81 years. So you see, it's more commonly if you want to use in the elderly age group, you're using the you see the KEO value, you can compare. It was 1.2, here it is 0.456, right? So you see less. Then you know the names of the fixed parameters. There are different formulas which you use for calculating the lean body mass. I'm not going to go into the details. So this is a general comparison between the Marsh and the Schneider model. The important thing which you need to highlight is that if you see V1, the central compartment, you see the value is very less for the Schneider and it is fixed. Similarly, for V3, it is fixed. However, for the Marsh, you see that the value is significantly higher, 15.9 liters, and it depends upon the body weight. The other important difference is the time taken for the peak effect. You see, in Schneider, it just takes 1.69, right? When it's here, it takes 4.5. So this is the basic main difference between the Schneider model and the Marsh model. As a continuation of further the time to peak effect, you find that when the time to peak effect is small, so there is less overshoot, and it is because it is used effect site targeting, right? So you get less propofol administered with the Schneider model. So it's very safe when you use in elderly and the compromised patients, as compared to when you're using the Marsh model, right? And we already know that V1 in the Marsh is a function of weight. And the striking differences in estimated in plasma and effect site concentrations are generally in the first 10 minutes after the bolus. After that, the various compartments start equilibrating, and then you don't get so much of a difference. The best model till now is the leveled model. It's actually a one model for everybody, for all, right? And the number of patients which was studied, you see, is quite large. So that is one more very assuring factor if you want to make a choice of the models. The more the patients, the more, scrutinized your data is. It takes a lot of covariates. Important is that it is considering the fat-free mass, right? And it is also including age, weight, gender, co-medication. And we have already talked of that it has a very wide range of age groups. It can be used in pediatrics. The KEO values for propofol and remifentanil I have written. And the variable parameters and fixed parameters are, basically the variable are depending upon the weight and the age of the patient. So again, now this table has the level model also added to it. So the important difference which you really need to understand is that level is adjusted for concurrent opioid use, which is very, very important. And the KEO is a function of weight in level. It is using the fat-free mass, the L11. And on the other hand, the Schneider is basically for, effect side. Schneider is using the lower induction doses, right? And the Marsh, on the other hand, is using higher loading doses, which is a very, very disadvantage of the Marsh model. We do not want to give somebody a very high loading dose. So again, to highlight the features of the level, you are using fat-free mass predictor, adjustments for concurrent use of opioids. The prediction error is low, and it's a universal model for different patients. So although I have told you in my slides how we started the Marsh model and then we came to the Schneider, so I really want to emphasize that if I'm talking of various models, the best model, if you're starting your work with TIVA, and you are the younger population, so it is better you start working with the leveled only, right? Now, just a few words about the Kataria model and the PEDFuser model, which is being used in the pediatric age group. We find that the Kataria can be used only for children between 3 to 16 years. PEDFuser is used for 1 to 16 years, but now we don't have to really use the Kataria and PEDFuse model because we have the level model of it. Again, before I summarize, there are some limitations of the various models which I want to highlight. As discussed previously also, the Marsh model gives a very high induction dose, right? Especially if somebody is morbidly obese, then it is even more causing more error because it is using the total body weight. So it can cause a lot of hemodynamic instability, right? Schneider is, inaccurate dose predictions in morbid obese again can occur, but it is relatively safer. The leveled will, is the one which is the best, right? And now leaving propofol, we come to the remifentanil. So we have talked about that the Minto model is basically for remifentanil, and it also has age, lean body mass, gender, and height as the covariates. And the fixed parameter is V3. And I don't know, remifentanil is not very popularly being used. It's expensive also. So how the experience of some anesthesiologists with remifentanil may be less. So I think they can start with the propofol model and then move on to the Minto model. And it is not validated for pediatrics or pregnant patients. And it assumes generally linear kinetics. So when you give extremes of dosing or you use critically ill patients, so it becomes less accurate. But the remifentanil itself, the drug has a very short life. So even if, a little bit of overdosing occurs or you can always account for it. So some variability is permitted because the other TCI models for opioids have been also introduced. They have tried to use the level, the GEPS, and the METRI. I am not going to go into the details. They are just for, your introduction purpose to, the availability of models for opioids. I think once when we are using rampantly the Minto model for fentanyl, the utility of these models actually decreases. Nowadays, all in various surgeries, whether it is ENT surgeries or awake craniotomies, everybody is very fond of using dexmedetomidine. And as we had discussed in the previous slide also, that there is one issue with dexmedetomidine that, it takes a lot of time. You have to stop the drug at least half an hour or 40 minutes prior to your surgery end. Otherwise, it takes time for. the context sensitive time is very long. So keeping all this in mind, people thought that there should be a model, and the model was developed in 2015. It was by Henny Ward et al. And again, the number of patients they used were very few. There were 18 healthy volunteers. The covariate is again weight, and there are other models also, but dexmedetomidine generally is not very rampantly being used as for TCI because of the very high context sensitive time. So what is the target concentration which you need to set? Your knowledge is also very important. Like Dr. Shiv said, that before you start, he has given you a perfuse that, you should be very clear what age you are entering, what weight you are entering, because every calculation is based on what we enter. So it is very important that we enter the demographic values also correctly, and we enter our target plasma concentrations or the effect site concentrations also accurately, because whatever the algorithm is going to calculate is based on our inputs. So for propofol, generally when we are using plasma target, we use 2.5 to 6 mic per ml. It's a good range. So you should always, see clinically, also be vigilant in the OR, know your patient profile, and probably see the hemodynamics also. And then you can always decide on the plasma target. The effect site target which you use is generally 4 mic per ml if you're doing induction, and 2.5 to 3.5 mic per ml for maintenance. For remifentanil, the values are 2 to 6 nanogram per ml, and the effect site is 2 to 4 nanogram per ml. When you're using dexmedetomidine, you need to set a plasma target of 0.5 to 1.2 nanogram per ml, and the effect site of 0.5 to 1 nanogram per ml. So I think they are not very difficult to remember, especially for propofol. And you should always enter the correct targets which and demographics. So I think by the end of these two talks, you are very clear that till now, TCI is restricted to hypnotics and analgesics. Once when we are using it more frequently in our routine anesthesia practice, then there is always a future of, having incorporation of more drugs in these models. And we are not at present using remifentanil and propofol in the same syringe. Maybe it is possible in the future. And most of the TCI pumps are not tested in infants, in the obese or the very elderly and the critically ill patients. So when you start using these pumps in your clinical practice, try and use it in ASA1 patients. That is always the best technique. First use in patients which have a good therapeutic margin of safety if there is overdosing or underdosing. And then only when you are very well versed, you should go to the extremes of age groups. So the take home message is none of the model is universally superior. Each has advantage and limitations. But by the end, you can understand the Eleveld is the one which is, the most popular these days because of the advantages which I told you. And you should always stick to one model and start using one model, because that is going to give you more clarity of, of what you are actually doing. It is very important to use all your clinical skills and use depth of anesthesia monitoring device whenever you are giving total intravenous anesthesia, because you don't want any underdosing or overdosing, because each patient is different. There is a different pharmacogenetics, and propofol and these analgesics, they act differently on different patients. So drug titration is very important. Do not 100% rely on the algorithm. You use your clinical skills also. And safe administration of TIVA has already been discussed by Dr. Shiv. But titration is the key. Always in anesthesia. As an anesthetic, the first technique which we were always told is you have to titrate your drugs. Whether you give them bolus or you give them as infusions, whether you use manual or you use pumps, titration is the key. Thank you so much. And I think questions we can take later.
Yes, Tanvir. This be in a few minutes, and I will let you go and come back on that. So,
Yes.
to summarize your talk, we are moving towards a generation where we are talking about concentration of the drug rather than the dose. Is that right? So, we are talking about concentration of propofol in the plasma also in the effect side. So, and as time progresses, the parameters which are being used to determine has also got better. We started with using weight with the Marsh model. When the Schneider came in, we started using weight, height, and gender. And now with the Eleveld model, etc., you are using height, weight, gender, and also co-administration of drugs. And also the age range what we can use has also extended from neonate to 8 years. And these are validated in healthy people. When we use in sick people, we have to look for titration. Did we get it right? Is that the summary of your talk? And each pump when we have, there are various manufacturers of TCI pumps, and when each TCI pump will have various models. And you have given us a wonderful summary of what models to use and which model is beneficial in which age group. Wonderful. Thank you very much. There will be a few questions. We will come back to you at the end. And thank you very much, Dr. Tanvir. Now, the next in line is, Dr. Tanvir mentioned about now the anesthesia is we are focusing on concentration levels, right? Not on the dose, about concentration of the drug, and various algorithms have been worked out to determine what is the concentration probably in the plasma, what is the concentration in the brain, and we've also worked out what is the effect on the brain. And also Dr. Vivek will elucidate us what is the effect on the brain and how to monitor it. Now, when we have all these things, it makes a perfect conglomeration wherein which you can practice what is known as a closed loop anesthesia. And none better than Rajarajan Ganesh, who is here with us, who has used it practically in cardiac surgical cases in PGI, which Dr. G.D. Puri has brought it to us before any other people in the world. So I'm very glad that Rajarajan is here to share us his experience with closed loop delivery system. We can call it automated anesthesia delivery system. Dr. Rajarajan Ganesh is an associate professor in PGI Chandigarh, and he's one of those using this closed loop delivery. Rajarajan, we look forward to hear from you, and the stage is yours. We want to hear from you. Thank you.
Thank you very much for the introduction, sir. Good evening, everyone. And thank you, Shivakumar, sir, for giving me the opportunity to discuss about automated anesthesia delivery system. So I'll be talking first about what are automated anesthesia delivery systems. Then subsequently, I will move on to the effectiveness of the practically used systems. And then finally, we'll look at what we have to look in a system apart from the effectiveness of a system. So what are automated anesthesia delivery systems? So we are commonly used to using inhalational anesthetics. So in the context of inhalational anesthetics, when we have a case, we decide how much percentage of exhaled anesthetic gas that the patient should maintain, the end tidal value. So you can see here the end tidal desflurane. So now automated anesthetic delivery system is now inbuilt in a lot of workstations, where if you just tell the machine that you maintain this much of end tidal concentration, it automatically adjusts the flow rate as well as the dial setting to achieve the end tidal anesthetic concentration. This is a very basic form of automated anesthesia delivery system in which we can implement in our daily use. So this is about the inhaled anesthetic delivery system, which is automated. So after this, I'll talk about only intravenous automated anesthesia delivery systems. So in a closed loop delivery system, we have these are the features. We have a control algorithm, we have an actuator, we have a patient and a sensor. So the actuator in a closed loop anesthesia delivery system for intravenous anesthesia is a syringe pump. Through the syringe pump, we administer intravenous drug to the patient. So suppose you take the example of propofol. We attach propofol to the syringe pump and administer propofol to the patient. The patient develops changes in the EEG as well as the heart rate and blood pressure. So these changes in patient parameters, the EEG and hemodynamics, they are detected by the sensors. This value is provided as a feedback to the computer. The computer has an inbuilt algorithm. You must have heard from Dr. Tanvir that the TCI pump has an algorithm. So that algorithm is different. They are mathematical models which are incorporated into it. Here it is a closed loop model. We'll subsequently see what the closed loop algorithms are. So this algorithm adjusts the dosage of the drug. dosage of the drug which is administered through the actuator, and in this case, it is propofol. So this is the closed loop anesthesia delivery system. So similar to propofol, now there is closed loop anesthesia delivery system for almost all of the drugs. We have closed loop delivery system for alfentanyl, remifentanil, for muscle relaxants, and for vasoactive agents as well. So in this case, in each case, the feedback on which the drug dosage changes can be different. It need not be just EEG. It can be various other processed EEG parameters like patient state index. It can be the heart rate, blood pressure. It can be the analgo score for administration of opioids. It can be a train of 4 for administration of muscle relaxant. It can also be the invasive blood pressure for changing the dosage of vasoactive agents. So here the drug which is going to make the effect is known as the output, and the feedback which goes into the control algorithm is known as the input. So here the feedback which goes into the algorithm is the input, and the drug which goes to the patient is the output. So we can have different types of closed loop anesthesia delivery systems. For example, we can have a single input, single output, multiple input, single output, single input, multiple output, or multiple input, multiple output. We'll just see a few examples to understand what this means. So in the simplest form, we take the EEG as the input and we change the and give the dosage of propofol as an output. It is known as a single input, single output. And so for opioid like fentanyl, we take the heart rate and blood pressure as the input and we adjust the dosage of fentanyl as the output. So this is multiple input, single output system. And now we also have remifentanil. So we know that remifentanil also changes the BIS value. So whenever the EEG parameter changes, we may need to adjust either propofol or remifentanil. So the algorithm will decide which to change, and this will be known as single input, multiple output systems. So all these closed loop anesthesia algorithms have been done research on, and few of them have been practically evaluated also. So here the control algorithm is the brain of the system. Before going to that, we'll just see a small video. In this video, you can see the BIS value changing over here. And you can see the concentration of propofol, the target concentration of propofol over here, which automatically changes based on the BIS value. So the algorithm decides what should be the concentration of propofol, and based on the BIS value, it automatically changes the concentration of propofol. This is the closed loop anesthesia delivery system of a single input, single output, where the BIS is the input and propofol concentration is the output. So control algorithm. The control algorithm can be of many types. In the simplest form, it was known as adaptive control. So if you see target control infusion, just as Subramaniam sir had mentioned recently, so what they took was, they took a large number of patient population and they tested what was the BIS value at different effect site concentrations, and they drew a graph. But the problem is this graph doesn't stay the same for a patient throughout the surgery, and it is different between different patients also. So what the computer does is, it initially has a graph inbuilt in it, and it sees what is the effect of BIS when there is a particular effect site concentration. And then it moves the graph so that it changes the effect site concentration to achieve a particular BIS value. So this is known as adaptive control, and it was one of the earliest system of closed loop anesthesia delivery. Subsequently, more commonly used is the PID control, where based on the subsequent changes in the EEG value, it changes the dosage of propofol based on a proportional, an integral, and a derivative of the difference between the estimated and the actual value. And we have upcoming model prediction control, which is more smoother than the proportional integral derivative, so that we have a smooth course of anesthesia. And in another simpler form, we have a rule-based algorithm where the dosage is adjusted based on the change in the hemodynamics. Suppose there is a less than 5% change in hemodynamics, the dosage decreases by 35%. Less than 10%, it decreases by -6, and so on. So this is a rule-based algorithm where you tell the computer, if the heart rate decreases by this much value, decrease the dose of fentanyl by this much percentage. So it's a rule-based algorithm, and it is another simpler algorithm. So a common question people ask is it artificial intelligence? Is closed loop anesthesia delivery system, is it an artificial intelligence system? So if you refer to this diagram, artificial intelligence is a big subset, big set of algorithms in which machine learning is a subset of artificial intelligence. So in machine learning, the machine itself learns the algorithm, while in artificial intelligence, without machine learning, we give rules to the computer to change the dose. So artificial intelligence without machine learning are rule-based systems, adaptive control, and PID, while model predictive control, where the computer learns by itself, is a machine learning algorithm. So a closed loop anesthesia delivery system is an artificial intelligence based system, but not necessarily machine learning. So machine learning algorithms in closed loop are just upcoming, and we don't have any practically used system as such. So how to evaluate the effectiveness of a practically used automated anesthesia delivery system? So the first measure is the ability to maintain targets within set limits. So when we are administering propofol, we tell the computer maintain a BIS within a particular range of values. So we'll have to see whether the actual value of BIS is maintained within that particular range. If the algorithm does a good job of maintaining the BIS value within that target range. To evaluate this, there are a set of parameters which are used, a set of calculations which are done at the end of the case. For example, we see the performance error, median performance error, median absolute performance error, wobble, and divergence. These indicates the deviation, the bias, the inaccuracy, the within subject variability, and variability over time of how the algorithm is performing in maintaining the BIS within a particular target range. So whenever you read a paper on closed loop anesthesia delivery system, you'll notice these parameters. The next measure of effectiveness is the safety. So when we are administering propofol to a patient, when the BP or heart rate decreases, we make sure to reduce the infusion, or in some cases even stop the infusion. So we have to, when we are using the computer to run the propofol, the computer also has to do the same job. It has to either reduce the rate or it has to stop the infusion. So a closed loop anesthesia delivery system can be effective only when it incorporates hemodynamic stability as a safety measure. So we have a closed loop anesthesia delivery system which was developed at PGIMER Chandigarh by Dr. G.D. Puri, and it has been evaluated in a multi-center study. It was evaluated in Gangaram Hospital and GMCH 32 of Chandigarh. And in this study, they evaluated both the ability to maintain within set limits as well as the safety parameters. What we observed was, in both the cases, the CLADS group performed better than the manual administration of propofol through an infusion pump. The percentage of time the BIS was maintained within 10 of target BIS was also better, and the percentage of time the blood pressure and heart rate were maintained within 25% of baseline was also better when you used a closed loop anesthesia delivery system than a manual administration of propofol. So this closed loop anesthesia delivery system at PGIMER Chandigarh has now been upgraded. Earlier, it was only a single input, single output, which was based on only propofol and BIS, and the algorithm was a PID. Now it is a multiple input, multiple output. We have fentanyl also, which the infusion rate changes based on the heart rate and blood pressure, and it is a rule-based algorithm for fentanyl. And there is also an algorithm for norepinephrine or noradrenaline, where based on the blood pressure, the concentration or the infusion rate changes. So what about the clinical effectiveness? Is it enough if we maintain the BIS within a target limits? We have to look at more parameters. So closed loop anesthesia delivery system has been evaluated at multiple situations. This was one of the earliest study in 2012, where it was studied at Leh Ladakh at a high altitude. Here also it was observed that the BIS was maintained within 10% of the target. Not only that, the patients also woke up within a median of 3 minutes, and they were fit for discharge at 15 minutes. So this showed the clinical effectiveness even in extreme situations. The closed loop anesthesia delivery system has also been evaluated in pediatric cardiac surgery. In pediatric cardiac surgery, not only the dosage of propofol was lesser, it also led to better hemodynamic stability. In the pre-bypass period, phenylephrine we use when we expect that there is a excess anesthetic administered. The phenylephrine use was lesser in the closed loop group compared to the manual group. Not only that, the manual group required a median of 18 dose adjustments per hour. Within an hour, the anesthetist had to change the concentration of propofol on the infusion pump 18 times in the manual group, while in the closed loop group, it automatically adjusted the dose of propofol. We also evaluated closed loop in this very sickest of patients. It has been evaluated in patients with left ventricular systolic dysfunction as well. where again it maintained the target values within limit for longer duration compared to the manual group. And in this study, we also obtained values for the effect site concentrations for 50 and 95% of the population in this study group. And you can see Dr. Tanvir Samra and Dr. Varun Mahajan were the principal investigators of this study. So the closed loop anesthesia delivery system has also been evaluated along with other drugs. In this study by Gangaram Hospital, they evaluated the dexmedetomidine added to propofol in closed loop anesthesia delivery system, and they identified a consistent depth of anesthesia when dexmedetomidine was added, but the incidence of hemodynamic depression was more when dexmedetomidine was added rather than when dexmedetomidine was not added. So Gangaram Hospital has gone on to evaluate in further subpopulations also. This study was done in thoracic surgery, where the main finding was that the infusion adjustment frequency that was 9.6 versus none in the CLATS delivery group. So the anesthetist had to make less dosage changes when the CLATS was working. So in obese patients, Tanvir ma'am had mentioned none of the TCI models performed better. So many times desflurane is the preferred inhalation anesthetics because of its short context sensitive half-life. So when closed loop propofol was compared with desflurane anesthesia in obese patients, again at Gangaram Hospital, they found that the clinically relevant parameters of time to eye opening, time to tracheal extubation, and the ability to shift were all lower in the closed loop group compared to they were all comparable to the desflurane group when closed loop anesthesia was delivered. So closed loop anesthesia with propofol is a suitable alternative to desflurane anesthesia in obese patients. Similarly, it was also compared to desflurane in robotic surgery, where the duration of surgery is frequently longer. Apart from the dosage changes and the immediate observed effect, even on post-operative day 1, the quality of recovery was higher in the closed loop group with propofol compared to the desflurane group. Here you can see patients felt more rested, they had better sleep, they had more feeling comfortable in control, and they also had higher total quality of recovery score. They recovered better in the closed loop with propofol group compared to the desflurane group. So these studies show the clinical effectiveness of closed loop anesthesia delivery system, but the effectiveness may progress not only for the immediate post-operative period, but as Shivakumar sir mentioned, cognitive dysfunction post-operatively is a significant risk with inhalation anesthetics. Not only that, the cognitive decline post-surgery is higher when there is a lower BIS value, or when you overdose the anesthetics, there is a higher risk of cognitive decline. So closed loop anesthesia delivery system can help in preventing over anesthesia also. And in this study, where they use closed loop for anesthesia, for fluid management and ventilation, the cognitive score was better at 1 week and even at 3 months post-surgery when they use closed loop for delivering the anesthesia, fluid and ventilation. So this shows the clinical effectiveness of closed loop anesthesia delivery system. So if closed loop is so effective in maintaining everything within normal limits, why is it not so widely used? So there are factors apart from effectiveness which we need to look into. One thing is the number of manual overrides. So how comfortable is the person who is using the closed loop anesthesia delivery system? So it is ideal for a closed loop ideal anesthesia delivery system to have a backup manual mode in case the anesthetist has a doubt on if they are comfortable using the closed loop delivery system or not midway through the case, they can always change over to a manual mode. But we have to have a note of the number of manual overrides that are being performed during the case. That indicates how effective the algorithm is working. If there are more manual overrides, that means we need to improve the algorithm, or we need to improve the interface on which we are implementing the algorithm. The human workload. On one side, we say that the number of changes in drug dosages are less with automated anesthesia delivery system. But is that enough? Since we are introducing a computer between the human being and the patient, and the computer not only does what we say, but it also does what it thinks is correct, we also need the anesthetist to understand the system, understand how the algorithm is working, and whenever any change happens, the anesthetist needs to understand why that is happening. And also the closed loop delivery system will provide a lot of prompts and alarms so that we maintain the other parameters within the normal limits, and the anesthetist using the system must be comfortable using the prompts or alarm. So it is about finding the ideal balance and the training of the anesthetist in using closed loop anesthesia delivery system, which is important in overcoming the increase in overload because of these factors. And there are factors outside the closed loop also. For example, suppose we are using closed loop for control of blood pressure using norepinephrine. Norepinephrine is preferably used when there is vasodilation rather than hypovolemia or anemia. But the closed loop system will only identify a low blood pressure. So there must be systems which should alert the user to the presence of factors other than vasodilation. For example, if there is hypovolemia or if there is anemia, then the user needs to be alerted that something is not right. I'm not able to control the blood pressure with norepinephrine. So the present closed loop anesthesia delivery system at PGI identifies hypovolemia. So whenever there is a high pulse pressure variation, it doesn't just increase an norepinephrine dose, it also advises the anesthetist to consider fluid administration. Moreover, many times we have to preemptively administer anesthetics before even the change in BIS happen. For example, before incision of a patient, we may need to administer additional fentanyl. So in the closed loop anesthesia delivery system at PGI Chandigarh, we also have this option. Option is called pre-incision. So whenever this option is selected, it increases the fentanyl concentration to more than what was going on previously. So this is preemptively avoiding an increase in heart rate or blood pressure and also a BIS value. So there is much further future scope also for improvement in this closed loop anesthesia delivery system so that it is widely acceptable. One is artifact detection. So BIS can change whenever there is a cautery usage, and the blood pressure tracing can change whenever we are doing a sampling. So these needs to be identified by the system, and the system should not make changes in the administration of drug when the artifacts happen. So artifact detection is one area where the closed loop anesthesia delivery system can improve. For analgesia, right now there is no ideal monitor. Heart rate, blood pressure, nociceptive index are some of the monitors which are available. In the future, there may be more novel monitors which could lead to development of better closed loop systems. And finally, the brain of the closed loop anesthesia delivery system, the algorithm. So machine learning models are upcoming. For example, this machine learning model was published in 2024, where based on the data from previous patients, the model could predict the increase in dosage of remifentanil that was required. So these machine learning models in the future can help manage the preemptive dosages also. We saw earlier that whenever there was a pre-incision event, we had to select the pre-incision event. But in the future, the machine may itself learn to detect a event where we need to administer an increase in opioid. So to the take-home messages from this presentation are, so multiple automated anesthesia delivery systems have been developed worldwide. Many systems have been demonstrated effectiveness in maintaining targets within pre-specified ranges, and some show clinical benefit also in the short term as well as in the long term. Understanding the algorithms and their limitations is crucial to the anesthesiologist to make appropriate care decisions. Safety mechanisms and enabling good human-machine interfaces are crucial for the success of such systems. Thank you.
Thank you, Rajarajan. Wonderful talk. If you are one of those viewers here, don't go away. We have got very, very interesting parts now. Dr. Vivek is going to come. Before I hand over to Vivek, clarify a few things for everyone. So you have had personal experience with CLATS, wonderful experience, but this is an external computer on which these syringes are loaded, and this computer decides which kind of syringe pumps to use for this. Is it specially made, or what kind of things are they?
So previously, the commonly available syringe pumps was used. They were connected to a computer. Now the transfer of technology has been done to a company in India, Mohali. So they make a full set. They make the full set of syringe pumps as well as the monitor. The monitor has an integrated computer. So you just need a ventilator and the CLAT system to give anesthesia.
And to give the initial dose, what model does it use? Or does it use a model at all, or just the weight? How does it work?
Yeah. Initially, it starts with the Marsh model and gradually increases the dosages. So there is an option to select the acuity of the patient also. So based on the acuity, it determines the speed of increasing the dose.
And Acuity means what does it use? It uses BIS only, or what does it use?
It uses the ASA status and NYHA status.
And no, generally, for example, let's say if you have applied a EEG electrode, the contact is poor. What does the machine do?
So if there is no BIS signal at the start of the case, it doesn't start propofol at all. Suppose in the middle of the case, the BIS value goes away, it goes to a safe mode. So there is an option to select what concentration the patient loses consciousness. So it will make sure that that much concentration is maintained, provided the heart rate and BP are more than what the safety value which we have set.
Okay. So in case if the EEG stops coming or some problem is there, it has got a default mode. It will go to the TIVA mode rather than stopping. Wonderful. Thank you. So we look forward to your more participations at the national level. Thank you very much, Rajarajan. And now I will welcome Dr. Vivek Rayadurga. He's a fantastic friend. You know, we always reserve Vivek for the end because you want to have a dessert in the end, isn't it? So he's one of those who enjoys, who carries the tag of having a gold medal during his MD days, his DM in neuroanesthesia days, a very special friend, and who better than him to take us through how to use, depth of anesthesia monitoring. I feel thoroughly whether it is intravenous anesthesia or volatile anesthesia. Very important to know what is the depth of anesthesia. Now, if we don't use depth of anesthesia, for example, let's say all of you look outside when you're traveling by a car or a scooter. If you look outside, you will always know what speed you are going in. But can you predict you are going at the appropriate rates, not crossing the speed limits? No, you have to look through the dial and see what is the speed. Am I in the limits? Am I going over speeding or too slow? So having a depth of anesthesia monitor gives us clarity. Are we at the appropriate range? So Vivek, stage is all yours and people are waiting to hear from you. Thank you.
Thank you, sir. Thank you for that introduction. Whenever you introduce me as a friend, there is a certain EEG activation and the BIS goes up. So we will talk about BIS, and let me just share my screen. I hope everybody can see the screen. So depth of anesthesia is what depth of anesthesia monitoring is what I'll be talking about. So depth of anesthesia is the degree to which the central nervous system is depressed by a general anesthetic agent. It depends on the potency of the agent as well as the concentration to which it is administered. Now, why do we monitor depth of anesthesia in cases? While the main purpose of monitoring is to avoid introp awareness, the previous speakers have also elucidated that there is a growing body of evidence that suggests that anesthetics, particularly inhalationals, they produce long-lasting harmful effects. Now, if we assume that these harmful effects are dose-related, we would want to reduce the dose to minimum effective. We do not want to administer more than what is necessary. And to make sure that we are administering what is effective, we will have to monitor depth of anesthesia. And there is also evidence accumulating that deep anesthetic time or deep hypnotic time, where the patient spends a lot of time in deep anesthesia, too deep anesthesia, and that time that will lead to increased mortality in the post-operative period. We want to avoid that also. So for all these reasons, we have to monitor depth of anesthesia. Now, initially, people tried various techniques. Gödel brought out his stages of anesthesia. Then, to simplify that, there was the PRST score. But all these had one drawback. Now, this is a monitor under general anesthesia as per standard guidelines. We have the heart rate, we have the non-invasive blood pressure, we also have the arterial BP with its tracing, we have the saturation, and we have the temperature. Now, we would all agree that this is a standard temperature and the patient looks pretty stable on this monitor. But which of these parameters is looking at what is happening to the patient's brain? None of these. The main function of anesthetic drugs is to provide sedation or hypnosis. The cardiopulmonary effects which we routinely monitor, they are actually side effects. They are not the effects of anesthetic drugs. Patients can experience awareness or they can be too deep in the absence of clinical signs of light anesthesia or deep anesthesia, such as changes in heart rate or blood pressure. That is why a more direct and reliable method of measuring anesthetic drug effects on the brain is desirable. Now, whenever we talk about monitoring the heart, the most basic thing which we look at is the ECG. What ECG does, we attach leads at multiple points, multiple electrical waveforms are taken, they are all analyzed, and a final output is given on the monitor, which we all learn to analyze. Similarly, when we want to look at what is happening at the brain, what we need to look at is the EEG. There are multiple points here also where electrodes are connected. Each will give us a different waveform. They are all together analyzed, and the machine will give us a waveform similar to what it does with the ECG for the heart. Many anesthetic produce different characteristic, or they produce characteristic effects on the EEG. So since many years, people have been trying to use EEG as a monitor for anesthetic effect, but that was difficult because the processor, the technology needed was cumbersome. And with the development of inexpensive and fast microprocessors in the recent times, that has become easy. And as a result, many depth of anesthesia monitors have now come into commercial practice. We will have a look at a few monitors going forward. First is the bispectral index. Now that initially when it came into market, it was a standalone monitor, but as years progressed, as the proprietorship was taken out, it has now been integrated into our multi-para monitors. Now, this is a monitor, I would say, which is now complete. Along with all the other cardiac parameters, we also have the EEG and the processed EEG index, which is telling us actually what is happening to the brain, what the drug is doing to the brain. So BIS was the first product available for routine intra-op EEG monitoring, produced by Aspect Medical Systems. It is called bispectral index because the algorithm with which the EEG is processed and the index is derived at, one of the parts of the algorithms is bispectral analysis. That is why it is called the bispectral index. By far, it is the most extensively used, revised, marketed, and studied depth of anesthesia monitor. It comes with 4 electrodes. The standard sensor comes with 4 electrodes. The most important of these is the electrode 3, or the temporal electrode. This is the active electrode which is continuously recording the EEG activity of the brain. So logically, it has to be as close to the brain as possible. That is why what we'll do is we'll put it on the temple where the skull is thinnest, so that the electrode goes closest to the brain. Next is the frontal electrode, or electrode 1, which is the reference electrode. From ECG, we also know that whenever we are recording electrical activity, we record activity at one electrode in comparison to the activity of the second electrode. So the difference between them is what is projected as the waveform. Similarly, for BIS, the activity at 3 in reference to the activity at midline, or the electrode 1, is what is displayed on the monitor as the EEG waveform. Then electrode 4 is put on the eye. That is used for collecting EMG activity information from the frontalis muscle as well as the eye movements. And electrode 2 is the ground electrode, which will help us to nullify the electrical interference from other devices in the operation theater. Now, how BIS is calculated is by this algorithm, where the digitized EEG is first filtered out for artifacts. Then there are various processing which goes on, like suppression detection, fast Fourier transformation, bispectral analysis, then other forms like BSR and beta power ratio and sync fast. So these are all calculated, and finally we get a parameter. It is all very difficult to understand, but what we should know is that the BIS is a dimensionless index from 0 to 100. The higher the BIS, more likely that the patient is awake. When the BIS is 100, the patient is fully awake and is responding to voice. When the BIS is 0, the EEG is completely flat and there is no electrical activity in his brain. So when we are below 70, the possibility of recall is pretty low. And if we are 60, we are almost sure that there is no very less possibility of recall under anesthesia. But below 40, it becomes too deep. And this is where the burst suppression in the EEG starts. And that part is called dangerously deep. And that is what we want to avoid. So basically, we want to avoid being below 40, which is very deep, and above 60, which is light anesthesia. 40 to 60 is the range for surgical anesthesia. But the problem with EEG signals is that they're very small. While the ECG signals are in millivolts, and all the other electrical activity in the OT is in microvolts, the ECG is very big, so we can easily identify. The EEG signals are in microvolts also, like the other electrical activities in the theater. So for us to understand what is happening, we require substantial amplification of the waves. And simultaneously, they are also subject to interference by muscle action potentials or the EMG of the frontalis muscle or the eye movement, the noise from other electrical equipment like cautery or the monitors or the drills, etc., which can contaminate the EEG signal. So we can prevent interference by filtering out the higher frequency activity from where the interference comes. But the problem is that when the patient is awake, his EEG is most likely to be high frequency. So if you filter out those itself, then we will assume that there are only low frequency waves. We will think that the patient is adequately deep, but that may be falsely assumed because we have filtered out, we are not processing the actual awake high frequency waves. So that error possibility is there in BIS. So one thing which they did to help us was to provide an idea about the EMG also. So whenever you have put that electrode, the electrode will give us an information about EMG. What we know is that as long as the EMG is low, we know that there is less of interference and the EEG waveform and the index is reliable. So generally, if the EMG is below 30, we will rely on the BIS index. But if the EMG goes up, then because the monitor also analyzes that the EEG activity is going up, the BIS will falsely go up. So it is not because the patient is becoming light, it is just because the muscles in the vicinity of the electrode are moving and the BIS has become spuriously high. The other problem is that BIS has been devised mainly using GABAergic drugs like propofol, midazolam, and isoflurane. So in non-GABAergic drugs like nitrous oxide, which has little or no effect on BIS, or ketamine. Now, ketamine, which is an NMDA agonist, inherently it has the property of activating or elevating the EEG activity. So BIS will naturally increase. So the higher the dose of ketamine, there is higher the activation of EEG, higher the BIS, in spite of the patient going deeper. So in these cases also, BIS becomes unreliable. The next monitor which we'll look at is the entropy. Entropy basically means irregularity or complexity of a signal. So we know that when the patient is awake, the EEG is highly irregular. There is no synchrony between the waves. So the entropy is high. And as the patient goes deeper and deeper under sedation or anesthesia, the irregularity decreases. It becomes more synchronous. So the entropy decreases, and that is what happens on the monitor also. The difference between entropy, I'll tell you. So this is how the electrode looks like. There are 3 electrodes and not 4 like this, but the signal processing is similar. 3 is put on the temporal bone for picking up the EEG. 1 is the reference for 3, and 2 is the 2 serves as ground as well as it picks up EMG activity from the eye. This is the display on the monitor. We can see that there are 2 parameters being displayed, RE and SE. So RE or response entropy, that is produced by analyzing activity in a higher frequency range from 0.8 to 47 hertz. So that is made so that it also includes the EMG signal from the frontalis muscle. So because it is using a higher activity range, the display range also is higher from 0 to 100. State entropy, it only analyzes activity in the lower frequency range, that is 0.8 to 32 hertz. So it filters out the frontalis EMG signal in the high frequency range, and only the cortical activity is measured and displayed. Because it analyzes a lower frequency range, the range of display is also low, only from 0 to 91. So the difference between BIS and entropy is that now this is from our MBBS knowledge, we know that any EEG, when it is subanalyzed, we get different waves of different frequencies. Now this is the high frequency waves, which are known as gamma in the range of 30 to 80 hertz. Then there are slightly slower waves, or the beta, which is 14 to 30 hertz. Then alpha in 8 to 13, theta in 4 to 8 hertz, and delta in less than 4 hertz. This is a 1 second recording. If you count the waves, you will know what range it belongs to. What BIS does is that it eliminates the gamma range, because EMG frequency is also in this range. So this part is eliminated, and the remaining beta and below is analyzed to give us the index. But what entropy does is that it also analyzes the beta and below, below the 14 hertz activity, and it gives us state entropy, but it doesn't eliminate the gamma or the EMG part. It analyzes that part also, and then it assumes that that activity is happening because of pain or because of arousal, and all together we get the response entropy. So the difference between BIS and entropy is that BIS only analyzes below 14 Hertz and gives us one index, while entropy uses the filtered out part and assumes that it is from the EMG, and the EMG activity is because of pain, so it gives us response entropy also. For surgical anesthesia, entropy is being calibrated similar to BIS. We need to maintain the state entropy between 40 to 60. But the advantage is that if you measure the difference between response entropy and state entropy, so we will know that the difference between them is higher because there is higher EMG activity. Probably the patient is having pain, so we may have to supplement analgesic instead of deepening the plane of anesthesia. That is how you can use both the information to improve your drug administration. Other monitors which are now available are the SedLine from Massimo, which gives us the patient state analyzer. Here again, you can see that the main advantage is that the electrodes are bilateral, so you will get information from both the hemispheres, and you get other information like apart from raw EEG waveforms, you also get other information like this picture, which I will be describing in the coming slides. So that the range here recommended is to keep the PSI between 25 to 50. Here you can see it is 36. Then there is something called Narcotrend. When they came out, they wanted to be different. So instead of numbers, they gave letters starting from A to F. But because they did not become popular, they have also switched to numbers now, and they have calibrated it to be similar like this. You want to maintain it between 35 to 65. And this is a recent addition to the armamentarium, Conox. This gives also this like entropy, it gives two indices, QCon and QNOX. Con is for consciousness, that is calibrated like this. So you need to maintain between 40 to 60 for surgical anesthesia and between 60 to 80 for sedation. NOx is for noxious stimuli. So if you are looking at that, the higher the number, more likely that the patient is likely to respond to a painful stimulus. That is also picked up from the EEG signal, a different kind of processing. So they have recommended that the lower the value, the less likely the patient is likely to respond. So keep it below 40 so that even if there is a painful stimulus, the patient doesn't respond hemodynamically to that stimulus. The other advantage of this monitor is that it can connect with Bluetooth to your smartphone device. And even though the monitor is somewhere far, you can keep monitoring your patient remotely through your Bluetooth device. Now, this is a Conox monitor by Fresenius. But the limitations of all these devices is that these do not exclude the occurrence of entrop awakening. And the other problem is that they are sensitive to electrical interference, and when there is interference, because the EEG waveform goes haywire, and when the EMG activity interferes, the index becomes unreliable. And in population such as extremes of age or very elderly or infants or neonates, or with patients with neurological disorders like stroke or tumors, or with bleed in the brain, the index becomes unreliable. And like I said, they are only reliable for GABA drugs like propofol or inhalationals. When you're using ketamine or nitrous oxide, you cannot judge the actual depth based on those index. Whenever there is a problem with an index, what will we do? We like to understand what is happening ourselves so that we can come over the limitation. So when we have limitations in an index, we can do other things like visually analyze the raw EEG ourselves, or look at other information which is provided by the monitor so that our decision making is more concrete, or look at certain identity called density spectral array, which I just showed in the monitor. So if that is available, look at that, and that will help your drug administration be more reliable. And this will give us more better information so that we are not relying just on an index, but we are also making informed decisions ourselves. First is looking at the EEG. Like I said, EEG is the ECG counterpart of the brain. It is made up of waves with a variety of frequencies. But the difference is that unlike in the heart, once there is a stimulus from the SA node, all the myocytes, they fire as one. So there is one single activity which we get on the waveform in the form of a standard ECG. But the EEG, there is no pacemaker for the EEG. Every neuron fires in its own way and independently. There is no synchrony when the patient is fully awake. So there is no reproducible EEG waveform which we can study. But these people have analyzed and have realized that there is a wide range of frequencies of activity which are arising from different parts of the brain, varying from zero point 0.1 to 500 hertz. So just for our better understanding, they have divided into different, all the patients will have all the waves at all the times. Just for us to understand, they have divided them into gamma, beta, alpha, delta, and theta waveforms for understanding. Now, correct interpretation of the EEG is essential for decision making. We also need to identify the frequency and amplitude in each wave so that it can help us assess what stage the patient is. And but opposed to expectation, with some training, we can understand what is happening to the heart by looking at the ECG. But to train ourselves to understand the EEG, it takes time and practice. It is not as easy as with the heart. So just to illustrate, see, this is a raw EEG which is being displayed on the monitor, but it is actually a result of a mixture of all these waves simultaneously. So all these waves together, they are mixed, superimposed on one on another, and finally we get this output on the EEG. This is when the patient is awake. Our target when the patient is asleep is to suppress the gamma and beta waves, and we want the patient to be within the alpha to delta range. We want them below this range. We do not want gamma and beta waves in our patient, so that the patient is deep for surgical anesthesia. So how do we identify that? We can look at the EEG and pick up certain signals. Now this is an example of an EEG waveform, which without looking at the index, we can try to understand what is happening. There is something called suppression ratio. What is burst suppression? Burst suppression ratio is the time for which in the previous 60 seconds, the time for which the patient's brain had become completely silent. So the duration, if suppose for the in previous 60 seconds, the patient's brain was completely suppressed, there was no activity for 40 seconds. That means 60% of the time the patient's brain had no activity. So the monitor will give it as a burst suppression ratio of 60. In this picture, you can see that there is a flat line for a long time. The heart rate, BP, and all pretty stable, but you can see that there is a flat line for a long, and then there is a burst of activity, and again the brain has become quiet. Now this is burst suppression, and it has been proven that this is dangerously deep. If you did not have this, we would happily accept this heart rate and BP, and because the map is okay, we would continue to deliver the same depth of anesthesia. But once we have put EEG, we will realize that the patient is very deep and that we need to lighten the plane. Like I said, it is a state of profound brain inactivation. It is supposed to be similar to cardiac arrest. It is called brain arrest, and its appearance is related to cognitive dysfunction, post-op delirium, and even early post-operative mortality of up to 20 to 30%. The other thing which the monitor gives is the spectral edge frequency. Now, suppose we do not want to look at the index. What we can look at the spectral edge frequency. The spectral edge frequency means that it will tell us the activity of 95% of the waves. Suppose the SEF on the monitor is 14. That means that 95% of the waves at that time which are being produced by the brain are below a frequency of 14 hertz. I already said that we do not want beta and gamma, we want only alpha and below. And alpha is 8 to 13 hertz. So if 95% of your waves are below 14 hertz, that means your patient is properly deep. He's not too deep, he's not too light. So that is how you can use SEF as a guide to anesthesia. Generally, if you want to guess, BIS is twice SEF plus 16. So in this case, it's 14 into 2 is 28 plus 16 is 44. The actual BIS is 41. So even if you don't have this, if you have this, you can titrate your anesthesia. Now, the recommended targets are for sedation, you need to maintain an SEF of 15 to 20. For surgical anesthesia, 10 to 15. Whenever there is a slightly higher stimulus like laryngoscopy or skin incision, you can probably go a little deeper, take the SEF to 8 or 9, but they never go below 7 because that is too deep. So this is one way of titrating your anesthesia based purely on the EEG frequencies and not looking at the index. So this is just a flow chart to tell you how to practice anesthesia looking at SEF. First, once you have put your EEG monitor, make sure the gain is proper so that you can analyze the waves and then rule out artifacts. Once you have done that, first thing you see is to see whether there are any isoelectric intervals. If that is there, you don't have to see anything else. Directly reduce the concentration of your propofol by 15 to 20%, or stop it completely for 3 minutes so that the isoelectric activity, the burst suppression, goes off. Once that is gone, look at the SEF. If the SEF is still less than 10, that means the patient is still deep, decrease propofol infusion by 10%. If the SEF is more than 16, that means the patient has become light, so increase the propofol concentration by 10%. So you keep playing around with your propofol concentration here to maintain an SEF in the recommended range. And the last part of the talk will be density spectral array. Now, density spectral array, it is a color graph that will tell us what is the strength or what is the power of each frequency of the wave of each frequency at that point in time. So how it does is the power is expressed in scales. If there are more waves, then you get a red color for that frequency. If there are no waves, you get a blue color for that frequency. And if there are some waves, you get a yellow color. So here you can see that there are more waves in the low frequency range and in the mid frequency 10 to 15. There are no waves in the high frequency range, and there are probably some waves in the 5 to 10 hertz range. So this is a picture of density spectral array. Basically what happens is whenever an EEG waveform is presented, that is broken down into its component waveforms, and then the monitor will plot out what is the number of waves of each frequency on the graph. The higher the number of waves will get a red color, and the lower frequency range will get an yellow color. So at each point, one such graph is plotted, and then that happens every 2 seconds. So every point is then plotted, and together we get a final output like this, which is called the density spectral array. Just looking at that, we can identify what is happening. Now here you can see that there are waves in all frequencies. So the patient was awake. Here an anesthetic was administered, and suddenly the higher frequency waves got silenced, and we had only alpha and delta. So the patient was induced at this point, and the patient reached adequate depth. Here during surgery, we did not have any high frequency waves. We only had the alpha and delta. So this is how surgery was happening. And again towards extubation, once everything was cut off, the frequency increased. We got back all the waves of all the frequencies. So here extubation happened. So just looking at the pattern, you can identify what was happening to the patient. And certain other phases also you can identify. Now here the patient was pretty okay. There were just alpha and delta waves, and suddenly here the EEG activity has picked up. We got higher frequency waves also. So probably there was a nociceptive stimulus here. There was no adequate analgesia. That is why EEG activity increased. And so then they administered an additional dose of analgesic, or probably deepened the plane of anesthesia, and we got back what we wanted. No high frequency, only mid and slow frequency activity. And here again, it was going well. The patient was going smooth, no high frequency activity. Suddenly here there is a lot of high frequency activity. That is probably because the patient threw a seizure, and like we know, seizures are high frequency synchronous waves. So there is a lot of high frequency activity. So we could identify a seizure also under anesthesia just looking at the DSA. And the other pattern we are worried about is the burst suppression. See here, there was some waves here and some lot of waves in the low frequency range. They have added another propofol bolus, and after that everything has become blue. So that means there was no activity, EEG activity from the brain. That means the patient had reached burst suppression. We did not want that, so they had stopped administration. Slowly, slow frequency waves started coming here, and here the high mid frequency waves also came in. This is the pattern we want under anesthesia. So here the patient has come back to proper depth. So just looking at the picture, we could identify burst suppression. We could identify how long it was and how long the patient took to come back to that point. And the drugs also have certain signature patterns on the DSA. Propofol, when we are sedating a patient, it is known that propofol and low concentration only inhibits the inhibitory activity. That means there is paradoxical stimulation of the cortical neurons. So there is a lot of high frequency activity along with the baseline of delta activity. So there is a lot of beta activity and delta activity. Now, this is the signature of propofol sedation, a combination of delta and beta gamma waves. As we increase the concentration of propofol, when we reach surgical anesthesia, we have only the alpha and delta waves. This is typical of propofol anesthesia. It is called the alpha and delta pattern. We do not have any high frequency activity, it is blue here, and it is here. So there is a lot, what in general terms what they say is a lot of sky and a bit of fire at the ground. That is what we want under general anesthesia. Ketamine, like we have already said, it doesn't suppress EEG, it paradoxically activates. So we can see that there is a lot of red in the 30 to 35 hertz range, where beta gamma range. So there is a lot of activity in that range. That is typical of ketamine administration. And dexmedetomidine in the lower doses, it causes just uniform suppression of all the waves. There is just low delta activity. But as you increase the depth with dexmedetomidine, there is 11 to 16 hertz spindle activity is called sleep spindles, which appear in the range of 11 to 16 hertz. So with deeper dexmed sedation along with delta, you also have sleep spindles in the 11 to 16 hertz range. That is typical of dexmed. And again, inhalation anesthesia, when you are less than 1 Mach, it is similar to propofol. We have alpha and delta, but with deeper inhalation anesthesia, more than 1 Mach, the alpha waves disappear. We only have the theta and delta waves. That is called the theta on delta pattern. So to summarize, the depth of anesthesia monitoring is becoming widely used, and evidence shows that this monitoring improves outcomes by reducing the incidence of awareness and also by reducing the amount of anesthesia that is administered. So there is better recovery, better wake up, and also probably reduced nausea and vomiting. But there are limitations. Currently available algorithms do not account for all the drugs. They do not account for all the population groups. They are susceptible to a lot of interference. And also we should always remember that the depth of anesthesia monitor is purely a cortical activity monitor. It only analyzes the EEG. The response to pain or the movement to pain, which is traditionally used as a depth of anesthesia monitor in clinical settings, is a spinal response. And the depth of anesthesia monitors do not look at what is happening at the spine. So just because the patient is deep or just because the BIS is below 50 or 40 or even 30 doesn't mean the patient will not move. The patient can still move if the analgesia is inadequate. So they are only reliable when as a monitor of the hypnotic component, not of the predictor of movement. So this is just a chart to tell us how to titrate our drugs based on BIS. So and sympathetic activities. So if the patient is stable and the BIS is 40 to 60, continue using. Otherwise, try to increase the analgesia, try to increase the sedation, or you can also use sympatholytics or vasopressors to reach the targets which you want. Thank you.
Vivek,
Thank
I
you,
can
sir.
safely say, as the presentation went on, it became please be online. Swastika, any questions for the panel?
Sir, no questions today in the panel.
Okay, if there are no questions, I will give half a minute to each of you. Before that, I want to offer from all of us, Jayashree ma'am, thanks for giving us the time. The Indian College of Anesthesia, which we all revere a lot, for giving us the platform. Under all your senior people guidance, we have started a
Thank you so much, Dr. Subramaniam. Thank you so much, yourself and your team, Dr. Shivakumar, Dr. Tanvir, Rajarajan, and Vivek, for having such a wonderful webinar on this latest topic of TCI and TIVA. The topic was very well covered, and I'm so happy to really share that we in the Gangaram Hospital are probably one of the leaders in the publications in this field, and that makes us feel very proud. And the consultants who are practicing this CLADS in our hospital in the TCI, they are really so addicted to it that they do not do any case without that. So definitely a very important technology that has come in our armamentarium, and the topic was covered so well by all the speakers. So I'd like to thank you all from the bottom of my heart for this lovely webinar. Thank you so much. Thanks a lot. Good night.
Thank you, madam.
Thank you,
Good
madam.
night. Thank you so much.
So
Good night.
thank you so much everyone for joining this session. Clarnet is
Thank you,
really glad
Swastika.
to have all these people together.
Dr.
So
Subramaniam wanted to talk something, I think.
yes, sir.
Just a minute. Sir wanted to say something.
Sir is muted.
Sir,
I
muted.
think this didn't want me to take it longer. It's been a long day, madam. Thank you for giving us the opportunity, and it was wonderful talk. I want to thank everyone, madam, you, ICA, and all of you.
Yeah.
It was a very good learning session. Thank you, ma'am.
Thank you. And we are really looking forward for further participation of you and your team.
Thank you,
Thanks a
ma'am.
lot. Good night. Good night.
Thank you. Good night. all.
Thank you,
Good night.
Swastika. Thank you
Thank you,
so much. Thanks, Vineet, for
Yes,
anchoring the
ma'am.
show.
Good evening, ma'am. Good evening, everyone.
Thank you. Good night.
Thank you, ma'am.
Good
Thank
night.
Mhm. Mhm. Swastika, you may close the meet now.
Yes, sir. Sure.
Thank you.
Yes, sir. Thank you.
Mhm.